Senator Augustine is dressing up. Looks sharp.
Good afternoon, everyone. The Senate Finance Committee is now in session. I'll do a quick rundown of the order of the bills that we'll be hearing this afternoon. Initially, we'll start with Senator Rosa Pepp, Senate Bill 896. Senator Quarterman, Senate Bill 869. Senator Quarterman, Senate Bill 865. Senator Washington, Senate Bill 923. Senator Casemeyer, Senate Bill 815. Senator Carozza, 891. And Senator Salem, Senate Bill 423. We're starting with Senator Rosa Pepp. And Senator, you have as much time as you need to lay out the parameters of your bill. And I see that your lead witness is, well, you don't really have a lead. All right. So, and any other witnesses will have 2.5 minutes each. Okay.
Thank you, Madam Chair. Great to be back with you. This bill came out of the leadership work group that Senator Bidel and Senator Augustine and Senator Hayes served on with me, looking at what we need to do in the consequence of the COVID crisis, both health-wise and economically. And one of our recommendations was to set up a study commission, a work group, looking ahead. I think everybody here knows, not because they lived through it, but because they've read about it and our parents and grandparents lived through it. We've had the biggest disruption of our country since World War II over the last year. And it's changed things in a bunch of ways, accelerated some changes that were coming about anyway, but also brought some changes that weren't expected. And so the concept here is simply to set up a work group over the next 1.5 to 2 years, bring together policymakers, thinkers, to say what's changed, what hasn't changed, not how do we get through the pandemic, but how do we have the economy particularly, but also our institutions function well and better as they go forward. There's simple examples. Obviously, and this committee's dealt with many of them, all the issues related to telehealth, all the issues related to unemployment compensation. The EHE has dealt with the issues related to online education. And then we know in our own districts that the accelerated trend towards online commerce has an impact on our retail industry. We know that people, just like we're doing right now, teleworking may change the market for office space and community development. So there are a lot of trends. Some that are sharp breaks with the past, some are continuation, acceleration of existing trends. And the idea is to put together a group that spends serious time focused on what have we learned, where are we going, how to be intentional about making the state better off economically and institutionally going forward. The bill also includes a $500,000 appropriation, that not technically, but it says, let's spend $500,000 on consulting help. This would be staffed by DLS, but we don't want to overwhelm DLS. And I have to say that I was very impressed, whether you agree with the recommendations or not, with the process that the Kirwan Commission had, because they had consulting money. And so they were able to get additional resources to help with analytical work to supplement DLS. And so this proposes that DLS be able to contract with additional expertise to help with this program. That's it, Madam Chair. Happy to take questions.
Yeah, let me just start with one. Kirwan had a more defined goal.
I agree.
Knew kind of where the impediments were. It knew what the needs were, and we had to figure out how to get there. Here, it's going to be hard, it seems to me, to tell when this work group even ought to begin, because you don't kind of know how we will determine that we've come to the end, or practically to the end of the impacts of COVID-19, so that you know the scope of what it is you're studying. What would you say about that?
I'd say it's a good question and a good point. My answer to that would be we got to get started now. I don't think this starts when the pandemic is over, because when the pandemic is over is not clear. It depends how things play out with the vaccines. It depends how many people get vaccinated. So that's uncertain. But the particularly economic impacts and institutional impacts we're seeing right now. And so I think we should get started. I think you're right. It's different from Kerwin in the sense that sort of the solution was more focused at the beginning. I think the first part of what this group should be look at reality, is get the numbers together. We have anecdotal evidence of what's happening with teleworking is a great example. We have anecdotal evidence, but work is starting to be done nationally and internationally on trying to project what is going to be the impact on what kinds of employers, what is going to be the impact on what kinds of real estate. I think that's the kind of analytical work that we can frankly get started on this year, and then use that kind of hard information to think about how does that affect our community development policy? How does that affect our state workforce? How does that affect our labor laws?
And that takes me back to my question.
Yep.
I think it's too early to know the scope of what's happening to us, and even to define where the parameters are that will be your boundaries, what it is to be studied. We could, in some ways, be in a lot better shape in 6 months or 9 months. We could 18 months or 24 months from now find that some of the loosening of restrictions right now will cause it to flourish more, and with all these variants, and that things are much worse and we still are nowhere near the end of it. And that's why I wonder if this might be a little premature.
And I respect that, Madam Chair, and I understand your uncertainty. I totally agree with your uncertainty. I'm just a great believer as luck comes to those who plan. So that's the theory behind it.
Okay. All right. Are there other questions? Okay. If not, then we're going to the witness favorable with an amendment, Reverend Kobe Little on the ACP Maryland.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. Happy birthday to Senator Augustine, and thanks to Senator Rosa Pepp for offering this legislation. I am Reverend Kobe Little, and I'm here today to offer support to Senate Bill 896 with amendments. And I'd like to start off with the statement that recovery requires equity, particularly when it comes to seats at the table. And so my amendments will speak to several equity questions. I appreciate, Madam Chair, your concerns about whether or not this legislation is premature, but I tend to agree with Senator Rosa Pepp that there's no time like the present to begin to begin the thinking on these issues. So as it relates to the contracted consultants, I would offer that the bill should be amended to say that at least one of the contracted consultants must be able to demonstrate a history of working on equity issues related to COVID-19 response. I also think that where the legislation begins to speak on the work of this work group, where it says the work group should, that should be amended to say that the work group should make recommendations regarding how the state may best cope with the economic challenges posed by the COVID-19 pandemic, and addressing the equity considerations and issues specific to Marylanders experiencing economic insecurity when considering the economic effect of the pandemic on. And then the legislation goes on to address specific areas. Now, considering my statement that recovery requires equity when it comes to seats at the table, I think that it's important to expand the membership of this work group. I think that the Attorney General and his office have done outstanding work on COVID equity issues and response issues, and they have convened a task force. I definitely think that the Attorney General or a representative of his office should be a part of this work group to bring to bear their experience in addressing these issues. I also think that while senators and delegates are representative of the citizenry, there are important advocacy voices that should also be included at the table. This legislation would have the work group to speak on the next steps for public health in Maryland. I don't think that you can have that conversation without including the deans of our schools of public health as parts of those conversations. I don't think you can effectively have that conversation without having at least one health officer from a large jurisdiction and
You're
one.
almost out of time, so you got about 30 seconds.
Yes, ma'am. I'm gonna do it in 29. One
Okay.
health officer representative of a small jurisdiction. I also believe that the NAACP and CASA should be specifically named as organizations that would contribute members. I think it would also be beneficial to have the Maryland Consumer Rights Coalition and the Public Health Association and an education policy organization like Strong Schools Maryland involved. So I certainly thank Senator Rosa Pepp for this important legislation, and I thank the committee for your consideration of my amendments, which will be forwarded to the committee in writing.
Thank you. Are there any questions for Reverend Little? Okay, seeing none, then that ends the testimony on this bill. Thank you very much.
Thank you.
Okay.
Thank you.
All right, we're going next to Senate Bill 869, Senator Quarterman.
Thank you, Madam Chair and members of the Finance Committee. For the record, Senator Paul Quarterman, District 2, Washington County. Thank you for the opportunity today to present Senate Bill 869 to you. This bill would add a Western Maryland MARC rail extension study to the Maryland Department of Transportation statewide transit plan. This study will provide up to 3 recommended routes of extending rail into Washington County and beyond, as well as the feasibility and cost of those extensions. The bill also indicates that if the statewide transit plan is postponed or altered for any reason, that this specific study would continue to move forward. Western Maryland is home to one of the largest areas of the state that is not currently served by commuter rail. Studying the feasibility with the goal of extending rail to Western Maryland would open up potential for greater job accessibility, increased tourism, and a reduction in traffic on Interstate 70 and 270. Less vehicles on the road will equate to a reduction in pollution and ultimately cleaner environments. And additionally, rail service would provide significant relief congestion on the roads with the highest volume during peak hours, thus increasing highway safety throughout our interstate system. Commuter rail would also provide access to higher paying job opportunities, particularly to those that can't afford to buy, insure, and maintain a vehicle. The construction and maintenance of a MARC extension in Western Maryland would also provide significant economic development opportunities throughout the Western Maryland region. The Department of Transportation has provided a letter advising that this is duplicative of some of their statewide transit plan and state rail plans that they're currently undergoing. Yet it goes on to say they're examining parts of this legislation by examining transit in Western Maryland. Here's the issue, though. They may be examining parts of transit, however, they're not looking at the expansion of MARC. For 4 years now, we've been asking MDOT to look into this. And it was only after last year when we had a bill in the House that they would even engage in a conversation. All that we're asking for is this study becomes a part of the broader statewide study. The plan indicates they're looking at transit needs for the next 50 years, and MARC extension to Western Maryland should be in that conversation and in that plan. The bill does have an amendment that we have drafted that would add in regards to some of the concerns that the department had with CSX, where we would encourage the department would engage in CSX in an effort to answer some of those questions. CSX clearly came to an agreement with the state of Virginia recently, and there's no reason that Maryland should not be able to have those same discussions with CSX. This bill has broad support. It's been identified as a priority of the General Assembly's Maryland Transit Caucus, which is a bipartisan caucus of senators and delegates throughout the state of Maryland. You also find letters of support from the Washington County Board of County Commissioners, the Allegheny County Commissioners, the Mayor, the City Council of Hagerstown, and many other leading transit advocates in the state. The bill last year passed unanimously out of the Environment and Transportation Committee in the House, subsequently passed the House floor and came to this committee. However, it was heard on the last day of hearings that we had right before the session ended early. We're hopeful this bill will now come out of this committee, and we thank you for your consideration today and respectfully ask for a favorable report on Senate Bill 869. Thank you, Madam Chair.
Okay, are there any questions? Okay, well, let me ask you this. You do need some funds in order to conduct this study, and it looks like, according to the fiscal note, they're saying 900,000 in FY22 and 1.1 million in 23. What would you like to see reduced elsewhere in the budget to produce the funds that would be needed?
Well, no, and I appreciate that question, and thank you for that question. In some of the conversations we've had with MDOT in the interim, See, here's the thing, Madam Chair. They've told us that they would do this and they continually not do it. They told us they could handle it within their budget and they continue not to do that. So as far as something specifically, I would allow that up to MDOT, but they have come to the table and said that they would do this, but they just repeatedly don't do it. So my understanding is the funding is available within their budget. Just for whatever reason, they have chose not to pursue it and using this broader term of they're looking into things and continually are looking the other direction. So our belief is the funding is there. They just would have to make that decision on their own.
Okay. All right. Your lead proponent is Benjamin Ross from the Maryland Transit Opportunities Coalition. We'll hear from Mr. Ross now, and he has 5 minutes. Your other witnesses will have 2.5 minutes each.
Thank you, ma'am.
Thank you, Madam Chairman. I'm Ben Ross. I'm chair of the Maryland Transit Opportunities Coalition. I think it's no secret that Western Maryland faces some economic challenges. And one thing we know about rebuilding economies is that you don't succeed by simply trying to copy everyone else. You have to succeed by capitalizing on the natural advantages that enable you to outcompete others in some area. And one of the great assets of Western Maryland is its railroad heritage. It's got people, it's got skills, it has facilities, and it has the communities that grew up around the railroads. These assets are currently in short supply nationwide because both people and employers are looking for locations near railroad stations. Now we have a prospect of federal investment in rail infrastructure on a much larger scale than we've had in recent years. And that puts Western Maryland uniquely posed to benefit from that kind of investment. What this bill will do is put the region and the state in a position to seize on that opportunity. Now, let me be more specific. We believe that that there is an opportunity to build a MARC connection to Hagerstown at an unusually low price, really surprisingly low. There's an abandoned B&O railroad line, partially abandoned, that would connect the MARC system to Hagerstown. And it's the parts that are abandoned are in, basically open countryside, so that the price would really be, looks like it would be extremely low to build that as these things go. But clearly there are other options, and clearly you don't make an investment of this kind that's got to last. It's, these are 50, 100-year investments. So you have to do a study first and look at the alternatives. And again, that's what the bill does. So with that, I'll conclude my testimony. And I think that this is really a unique opportunity for the state. And we really, to extend MARC to Western Maryland, and we really, really need to take advantage of it.
Okay, thank you. Are there any questions? All right, I don't see any. So thank you very much for your testimony. All right, we're going next to Brian Dittor, the Maryland Sierra Club.
Hello, my name is Brian Dittor. I live in Silver Spring. I'm a volunteer speaking on behalf of Maryland Sierra Club, which is more than 75,000 members and supporters in this state. We strongly support the Western Maryland MARC rail extension study for a number of reasons. First and foremost, extending MARC rail to Western Maryland would enable more people to take commuter rail and leave their cars at home, which would lessen road congestion, lessen demand to expand roads, and decrease the total amount of air pollution emitted from vehicle tailpipes. The transportation sector is now the top generator of greenhouse gas and other health damaging emissions in Maryland and nationwide. The more people use transit and not their cars, the better it is for our environment and our health. Extending MARC Rail to Western Maryland also would encourage more economic development along its path, especially transit-oriented development at its stops. Having fast regional mass transit would improve mobility choices for commuters in Western Maryland, as well as regional travelers. And working couples could get by with not owning a car, or perhaps just a single car, if one or both spouses took MARC to their jobs. Our governor and MDOT have consistently said for years that MARC expansion was virtually impossible in Maryland because CSX, on whose tracks MARC service runs, was unwilling to negotiate expansion of MARC service. However, with shipments of coal steadily decreasing over time as more renewable energy becomes available, CSX will likely be more receptive to the possibility of sharing its rails more with MARC to generate more income. And as the senator noted, Virginia has negotiated an arrangement with CSX to expand commuter rail in Virginia, so it seems reasonable that Maryland could do the same. In summary, a study to determine the feasibility and cost of extending MARC rail service to Western Maryland is warranted because of the many benefits such an expansion would bring. We urge the committee to issue a favorable report on this bill. Thank you.
Okay. There is one impediment, a possible impediment, and that's what the department has estimated to be a $2 million cost to do the study over the course of 2 years. You have any ideas about how to lessen that burden?
Well, I think as the senator pointed out, MDOT has money in their budget. They just have chosen not to spend it. But since they're doing a transit plan for the state, it's reasonable to have this be a part of the preparation of that transit plan. I think this is just MDOT trying to not have a commitment forced on them. I really think this is reasonable to be included as a part of their normal study, which would be not an increase in funds to the state.
Okay. All right. Are there other questions for this witness? Okay, appears not. So thank you very much for your testimony. And we're going next to Katie Nash from the town of Hancock.
Yes, ma'am. Good afternoon, Chair Kelly and members of the Senate Finance Committee. Katie Nash on behalf of the town of Hancock in support of Senate Bill 869. The town would like to offer our gratitude for the introduction of this legislation and for the committee's consideration. We are excited about this step forward to consider expanding public transportation options in our region. And thank you to Senator Quarterman for your leadership on this important long-term vision. In addition to our written testimony, the mayor asked that I relay our appreciation for your work, Finance Committee, on behalf of Marylanders. We know that as a committee, you're managing tough subjects directly related to the pandemic, and we know that you're committed to a strong economic recovery. And respectfully, we believe that this legislation is closely tied to that ongoing work. The town of Hancock is located at the junction point of I-70, I-68, and US 522. And we believe that the town is an ideal access point for mass transportation. Moving this legislation forward will provide our region with a clear vision to take action. And we are fortunate that Senator Quarterman and our Senator Edwards, have decided to take a proactive approach to planning our transportation future. As a Western Maryland municipality, we are well aware, and the town does appreciate the need to prioritize resources. But it's our belief that investing in this study and including it in the statewide transit plan is a smart dedication of funds to ultimately provide the state with the next logical steps for Western Maryland transportation. And we know that smart planning always saves public dollars in out years. And for these reasons, I ask for your favorable committee report on Senate Bill 869.
Thank you very much. Are there any questions for this witness? Okay, I don't see any, so thank you very much. Okay, now that ends the testimony on that bill. We're going next, Senator Quarterman, to 865, And let's see, you have all the time that you need to lay out the parameters of your bill. Ronald Hayes, you've designated as the lead proponent, and that person will have 5 minutes, and other witnesses will have 2.5 each.
Yes, ma'am. Thank you, Madam Chair, members of the Finance Committee. Again, for the record, Senator Paul Quarterman, District 2, Washington County. Thank you for the opportunity to present Senate Bill 865 for you this afternoon. This bill is an extremely simple bill that it presents an opportunity to make an extraordinary difference within our EMS and healthcare systems. Currently, emergency service transporters in Maryland can only be reimbursed if the transport destination for the Maryland Medical Assistance Program recipient is a hospital emergency room. This bill would allow emergency service transporters across the state to be reimbursed for transporting program recipients to facilities other than emergency rooms exclusively. There are many times that patients can be treated for their ailments at other facilities, such as urgent care for minor injuries and illnesses, or perhaps a behavioral health center if an individual is suffering a mental health crisis. In this process, an individual will receive more targeted treatment at a facility that specializes in a specific type of care. Unfortunately, we've seen situations where the emergency rooms are overwhelmed, and in these situations, the emergency service transporters are then forced to wait with the program recipient at the facility until a transfer of care can occur. This takes emergency service transporters away from serving additional patients within the community, and thus can present a public safety concern within the greater community as well. This bill would allow our EMS professionals the ability to triage parents to the appropriate care, and in the process would help alleviate some of the pressures placed on our hospital emergency rooms. At the same time, it would help better serve program recipients by allowing more destination options. This bill has the support of the Maryland Institute for EMS Systems, along with the Maryland Association of Counties. There is a letter from the Department of Health, letter of information with some concerns of the bill statewide impact. We certainly would be open to this being a local bill if there is a concern of statewide implications. As such, we also have letter of support from the Washington County Board of County Commissioners, the mayor and the city of Hagerstown City Council, as well as Meritus Health, which is the only hospital that's located within Washington County. Again, thank you for your consideration here today, and we respectfully ask for a favorable report. Thank you, Madam Chair.
Thank you. Are there any questions for the senator? Okay, I don't see any. So we'll go to Ronald Hayes from the Washington County Division of Emergency Services.
Good afternoon, Madam Chair and fellow council and committee chairs and the committee itself. David Hayes, Director of Emergency Services for Washington County, and I'm here to offer support of Senate Bill 0865 for a multitude of reasons, many of which Senator Quarterman has already highlighted. And as you know, and probably most committee members do, many jurisdictions in Maryland rely heavily on third-party billing or insurance billing to cover costs. Back in the early 90s, we were able to sustain some of the EMS delivery model through heavy volunteer contributions in the smaller counties away from the metro areas. Most of the time, and prior to the 1990s even, the metro departments and counties had long-standing career systems and that were heavily subsidized by tax-based dollars. Washington County has a citizenry or a population of about 150,000 in total, of which about 35,000 of those reside within the city of Hagerstown. One of the biggest challenges to our county is that the EMS system is still provided by 8 independent EMS companies, all of which are volunteer owned and operated, but they've been forced to heavily rely on the addition of career staffing to ensure continuity and sustainability of services. In doing that, what had happened, it forced them to move from the traditional solicitations of fund drives, fundraisers into the billing model, the insurance billing model. And that is how Washington County, for the most part, manages its revenues for EMS transports. In total, Washington County in 2020 ran 29,791 incidents. Of those, 25,000, over 25,000 of those were EMS incidents in whole.
I think you accidentally muted yourself. Unmute yourself again.
All right, where did you lose me at, Madam Chair?
Maybe 2 or 3 sentences back.
Okay, so real quick recap, Washington County population is about 150,000, and the city of Hagerstown has a population of about 35,000. Just want to make sure that you did capture that EMS in Washington County is still provided by 8 independent volunteer corporations that for the most part use career staffing that they employ to provide the service due to the lack of volunteers. So with that, Washington County's total call volume for 2020 was 29,791. And of that, 25,027 were EMS incidents. So you can see clearly a large part of the service demand is dependent upon EMS resources and the ability to provide that. So as you go through that, and we get specifically to the bill's makeup, previously, and for what I understand, at least 20 years, the Maryland Medicaid reimbursement has been capped at $100 with no mileage, no additionals. And I don't know too many cost of doing businesses that haven't increased exponentially over 20 years. So with that, what we also know about the current statute is it requires an ambulance to provide a physical transport of the patient, and in this case, to a hospital, not an alternate care facility. And Senator Quarterman has done a great job of highlighting those additions and much needed revisions to the bill. A lot of our calls result in treatment but no transport, and a lot of those reside in the city of Hagerstown. So Community Rescue Service is our largest EMS provider, and again provides most of its service from corporate employees. And they alone in 2019, I don't have their 2020 numbers, ran just over 4,200 Medicaid calls for service. So if you look at some of the mechanics of the bill here, even at $25 increments per year increase, that is $105,000 of additional revenue potential for that single company. And I think you'd find that that is probably a story shared well with throughout the state. Most of the EMS departments in some of the smaller counties just simply don't have the tax base to fund a complete career EMS workforce. Washington County in whole has recently needed to hire firefighters, which also puts an additional burden on the tax base. And again, going back to the providers in whole, we're happy to see that the bill includes the language for the reimbursements of transport to alternate care facilities, and also considers language that will allow reimbursements for treatment without transport. So again, I want to articulate our support is offered in support of the bill, and we appreciate the opportunity to speak here.
Thank you very much. Are there any questions for Mr. Hayes? Okay, don't see any, so you must have done a good job. Okay, we're going next to Theodore Delbridge, Maryland Institute for EMS Systems, MEMS.
Hi there, good afternoon. I'm Dr. Ted Delbridge, the Executive Director of MEMS, the Maryland Institute for Emergency Medical Services Systems, responsible for oversight and coordination of Maryland's statewide EMS system. And we do that in part through promulgation of clinical protocols used by emergency medical technicians and paramedics throughout the state, and by issuing administrative guidance for EMS operational programs for those agencies responsible for delivering EMS. Senate Bill 865 would facilitate appropriate care for lower acuity patients, those who can be optimally cared for at somewhere other than a crowded and expensive emergency department. It would facilitate implementation of the Alternative Destination Protocol, which was approved by the State Emergency Medical Services Board in 2019. The protocol helps to identify lower acuity patients and enables EMS clinicians to transport such patients to designated predetermined care sites other than hospital emergency departments. In fact, 4 jurisdictions are actively working to incorporate alternative destinations into their standard operating procedures. 3 of them are participating in a federal CMS initiative to evaluate the associated cost savings and healthcare quality measures, and to emphasize cost savings. We believe Senate Bill 865 will acknowledge that not all EMS patients need expensive, high-intensity emergency department care. It will help to offset the cost to EMS agencies for doing the right thing for their patients and the healthcare system. It will help keep EMS services available in their communities, and it will do a bit to reduce emergency department crowding. Maryland has some of the worst in the country, with patients who can be cared for elsewhere. Thus, with those in consideration, we strongly urge a favorable report for Senate Bill 865. Thanks very much.
All right, thank you. Are there questions for the doctor? Any questions for Dr. Delbridge? All right. Well, you must have done a good job. They don't seem to have it. Thank you. Okay, and our final witness is Alex Butler from MACO.
Good afternoon, Chair, Vice Chair, and members of the committee. Alex Butler with the Maryland Association of Counties here in support of Senate Bill 865. I think the rest of the panel's done a fantastic job explaining the bill, so I'll be very brief. The bill simply creates a more reasonable standard for reimbursement under the state Medicaid for deliveries made by emergency transport. This bill gives EMS providers a path forward for reimbursements for the important work they do, even in the event they don't take patients to the hospital. In many parts of the state, the nearest fully licensed hospital facility is notably further than the nearest appropriate caregiver, and there are often other well-equipped facilities. There's a large safety aspect to being flexible with where patients are taking and how care is being administered, and it's fair that EMS receives proper reimbursement for the critical services they provide. Thank you to the bill sponsor and the committee for your consideration.
Okay, are there any questions for the witness? All right. Thank you very much. And that ends the testimony. We have no negative witnesses, so that ends the testimony on this bill. Thank you. All right, we're going next to Senator Washington, Senate Bill 923. Senator, you have as much time as you need to lay out the parameters for your bill. And Pam Casemeyer, she is your lead person, and she will have 5 minutes. Other witnesses will have 2.5 each.
That is, thank you. Thank you, Madam Chair, and thank you, members of the Senate's Finance Committee. This is my last bill hearing on this side. So I think I started with you and I'm ending with you. This is a topic that you're familiar with, obviously, medical assistance program, eligibility and disenrollment, and having to do with pregnant parenting, pregnant women. This body has extended and understands the importance of supporting women during their pregnancy. And what this bill does is it allows for there to be comprehensive medical and healthcare services for pregnant program recipient for the duration of their pregnancy, which is what we already do, and for a year immediately following the end of the woman's pregnancy. Under current law, we can extend it for 60 days, but we're going to make the case that we need to extend that for a full year. A majority of pregnant-related deaths are preventable. They often stem from a lack of coverage and access to care in critical time from birth, from changes in coverage that can disrupt their continuity of care. So we have a situation where they're getting good care during their pregnancy, a couple months after that, and then they're not getting care. So approximately 60% of pregnancy-related deaths reviewed by the State Maternal Mortality Review Committee from 2011 to 2015 were preventable. And this is regardless of race. To improve the health of both mothers and babies, this bill would extend the postpartum coverage period in Medicaid from the current 60 days to a full year. Medicaid is a key institution, as you know, and nearly half of all US births are financed by Medicaid. And I didn't know that until we did this research. And in some states, it's much higher. So why? The key reasons for extending are the following. To address the loss of insurance gaps in coverage among postpartum women in both the expansion and non-expansion states. 2, this 12-month postpartum period would allow a new mother to stay on coverage automatically. 3, it extends the Medicaid postpartum coverage period. The new mothers do not have to switch from providers and they could have a better idea of their health history because they probably have the same provider that they've had for the 9 months of their pregnancy. They could have that same provider for that next 2 months, and then she'd have to introduce to a brand new provider. This gives another 10 months of continuity of care. And it's found to actually improve child health outcomes. And at the end of the day, because we're improving child health outcomes and we're reducing deaths related to pregnancy and we're improving the health of the mother, so she's more probably able in a position to go back to work or to care for her children, we would save billions of dollars that are currently being spent addressing maternal morbidity. So with all that, I ask for your favorable report on SB 923.
Okay, before we go on to your various witnesses, the only problem I see is what's here in the fiscal note. Do you want to address the fiscal note or anything that you see that could be offsets?
I'm happy to work with the committee on that, but it is an investment. I will say it's an investment in our future. But I do often what our fiscal notes don't show is what we save. And so we're making an extension, but we can.
But that's what I was wondering. Have you seen anybody who's done a study or anything to show what if there were sufficient prenatal care would be set?
I believe my panelists will be able to address that research. Isn't that they're in the future?
Okay.
Thank you.
All right. Are there any other questions for our bill sponsor, Senator Washington? Okay, thank you very much. Okay, we're going then to Pam Casemeyer. She's representing MedChi, and she will have the 5-minute slot.
Hi, Pam Casemeyer here on behalf of MedChi, but also the American College of Obstetricians and Gynecologists and the Federally Qualified Health Centers, a broad range of provider groups, really talking about something that's become a national priority across the country in multiple states. Senator Washington did a great job sort of explaining the objectives and what the bill does. I thought I could use my time to add a little more detail to certain things. I can answer a little bit of your questions, Chair Kelly, and others that I may be able to anticipate even from the letter of the fiscal note or the letter of information sent from the Department of Health. First and foremost, this bill only applies to women who are otherwise eligible for Medicaid anyway.
Right.
Though concerns about this opening it up to non-Medicaid eligible women, immigrants, or others, this isn't what this bill is focused on. This bill is focused on better outcomes within the population eligible for Medicaid. You should know, starting back, for years now, Maryland has a higher eligibility rate for a woman who becomes pregnant. You can qualify for Medicaid during your pregnancy. And for years now, 60 days postpartum, and that's the federal framework as well. So we've recognized for a long time that coverage for pregnancy has all kinds of positive outcomes, and we've allowed for higher eligibility. We're not changing the eligibility rates with this bill. What we've learned over the many years that the 60 days has been in place is that really there is so many health issues that arise actually 1 year postpartum, and that there is a lot of study in that. I can get you technical information and others from National ACOG, from clinical studies and the like. The other thing you should know is the infant that is born gets 1 year coverage. So this really would put the infant and the mom on a parallel track, which helps both of them in many respects. And it's been adopted bipartisan across the country. There's a lot of states talking about this now. And in fact, even at the federal level, prior administration and then the current administration, they're facilitating states passing plan amendments, which to a certain extent, Delegate Kelly, addresses your fiscal question, because then you get the federal match money, which makes it a significant difference in the financial cost to the state, because you also get federal dollars that match the state dollars, which reduces our fiscal note. So for instance, you have South Carolina, Texas, and California currently implementing it. If ever there was a good example on very bipartisan, different state philosophy on Medicaid, all acknowledging that this 12-month coverage has significant positive implications for the mom, just listing those states. And there's about a dozen other states that are in the midst of looking to implement it or filing a waiver or to get the federal match. So it's a work in progress, and we're excited to see that Maryland has this issue on the table as So to talk a little bit more, if one says, well, why does it take a year for the women's health issues associated with pregnancy? Part of what they find, and this has been found by our own maternal mortality review committee for maternal deaths in Maryland, you have things like maternal mental health issues that arise for a while that have implications for the infant and for the mother. You have chronic medical conditions that these women may have that get, I don't know if the right word, I'm not clinical, exacerbated immediately postpartum, and it takes a while to get them managed and back in a good place. And then you have some health issues that arise and they're triggered by the effect on a woman's body from pregnancy and delivery that they need to manage. All of that is not going to happen immediately. And so that's what our maternal mortality review committee has determined. That's why it's become a national conversation. And that's why we're hoping that we can work with you to move this bill forward. On one additional issue, at the very beginning of the bill, there's some language that we as my clients don't want to cause a slowdown on the conversation of extending postpartum coverage 12 months. It talks about the state developing materials to give to people when they transition off and disenroll. It's not really tied to the pregnant women piece, it's tied to Medicaid general. And we have some ideas on how to help provide information for disenrollment, but we do recognize why this department raised a question about that particular language. And we're already working on some suggestions on how to address a little bit of that without creating big question marks and problems for the real focus of the bill, which is the extension of the Medicaid coverage.
Okay, thank you very much. Are there any questions? Well, you made us a lot smarter. It might be helpful if you could send us back just a list of some of those projects that are going on in other states already.
Happy to do that.
Okay, then we're going next to Dr. Jennifer Viviciana. Belanchencio, the American College of Obstetricians and Gynecologists, and I'm sure I've messed up your name still, I'm sorry.
No worries. I'm Dr. Jen Villavicencio, and thank you, Chair, for having me and for the other members of the committee. I am a board certified obstetrician gynecologist, and I'm joining you today representing the Maryland section of ACOG, which is the nation's premier membership association for women's healthcare physicians and represents over 60,000 OBGYNs across the country. And I'm coming to speak in support of 923 because I care very deeply about the health and well-being of the mothers that I take care of. So this legislation, as you've heard, will extend postpartum health benefits of Maryland Medicaid to 1 year after childbirth. You've also heard that among the plethora of public health crises that are happening in this moment, they're all converging to intersect and worsen the US maternal mortality crisis, which is one in which the majority of maternal deaths, as you've heard, are preventable. Also one in which Black women are 3 to 4 times more likely. So there is a proportion of the population who is being disproportionately impacted by this crisis. Unfortunately, many obstetricians like myself have encountered a family impacted by maternal mortality. I will never forget the night that I stood holding the hand of the husband of one of my patients, explaining to him the catastrophic events that had taken place with his wife, talking to him and helping him decide whether or not he should stay in the ICU with his dying wife or go to the neonatal ICU to be with his critically ill baby. 30% of pregnancy-related deaths occur in the year after childbirth. So 1/3 of those happen after childbirth in that 1 year following. Research demonstrates that continuous uninterrupted healthcare coverage, as opposed to having a gap in your coverage while you're reapplying for pregnancy coverage, is one way to make a substantial dent in the hundreds of annual preventable maternal deaths, because it ensures that mothers who rely on Medicaid can continue to do so not only for their childbirth recovery, but also for the management of chronic health conditions, mental health care, family planning, and other critical healthcare needs. I want to be brief, and so I'll leave you with the story of another patient of mine who had a significant cardiac condition that made pregnancy and postpartum period very high risk. With excellent specialty care, she was able to safely carry her pregnancy and give birth to a beautiful son. She hoped to access cardiology care as well as a tubal ligation so that she wouldn't have another high-risk pregnancy after her delivery. Unfortunately, she lost her Medicaid coverage after those 60 days, and that was well before she was well enough to have her tubal ligation or even get in to see a cardiologist. She unfortunately returned to me several months later, and she was pregnant again and extremely worried about what her own life and the life of her family would look like having to enter into another high-risk pregnancy. Had she had access to a program like this one this legislation would enact, she would have not only been able to access treatment to improve her health and her cardiac condition, but it would be able to ensure the life she desired for her family by obtaining a tubal ligation. I ask you, as an OBGYN who is on the front lines every day, to see the incredible impact extending postpartum Medicaid can have for your constituents and your communities. I'm happy to answer any questions, and thank you so much for having me.
Thank you. Are there any questions for the doctor? Okay, good testimony. Thank you very much. All right, we're going next to Lara Wilson.
Thank you, Madam Chair and members of the committee for the opportunity to speak today. My name is Laura Wilson. I'm the Executive Director for the Maryland Rural Health Association, and I'm here today in support of Senate Bill 923. You just heard the importance of prenatal care and how lack of access to maternal health care often results in a number of poor health outcomes: premature birth, low birth weight, maternal mortality, increased risk of postpartum depression. And I'm here today to share how this is exacerbated in rural Maryland communities. Rural communities tend to have a higher rate of Medicaid coverage than urban areas. In fact, in 2017, Medicaid paid for an estimated 50 to 60% of births in rural areas nationally. Similar to barriers in accessing prenatal care, many women who live in rural areas may not receive the recommended postpartum care or follow-up visits due to geographic isolation, limited transportation, and lack of childcare, among other reasons. Between 10 and 40% of women do not complete a postpartum visit. Expanding access to these benefits takes away another barrier by providing the needed health coverage, which ultimately increases the chances for a healthy and safe recovery for mom and a successful first year for baby. MRHA believes this legislation is important for the health of our rural communities, and we thank you for your consideration.
Thank you. Do we have any questions for our witness? Okay, I see none. Thank you very much. All right,
You're welcome.
To Robert Brocado.
Madam Chairman, members of the committee, Barbara Brocado, and I'm here in support of Senate Bill 923 and on behalf of MEDNAX National Medical Group. And MEDNAX provides neonatal care across the state. They have neonatal physicians, maternal fetal medicine physicians, pediatric intensive care, and pediatric cardiology physicians treating moms and babies throughout the state. And I think that one point I want to add, Pam made the point about how important this issue is and how other states are acting. And I think there's some legislation pending in DC that may be being voted on today on this issue. But I also want to add that the President of the Senate brought together a work group, and this is in the end of your fiscal note, to look at a number of issues, and the recommendations came out in January of this year. And this extension from 90 days, 90 days to, or 60 days rather, to the 12 months is one of the recommendations of the President's work group. It also is a recommendation and one of the MEDNAX neonatal or maternal fetal medicine physicians participated in this with a number of other physicians, pediatricians, OBGYNs, in a task force, a piece of legislation that you passed in 2019, where they met for over a year and made this a priority. So I think others here have said it well. We're talking about saving lives. We're talking about addressing healthcare inequities. We're talking about prevention. Yes, we're talking about also a 2-to-1 almost expenditure, where I think 60-some% of the increase in these costs would be covered by federal funds. And I think we, and to a question, and I think, Madam Chair, your question about do we have any studies to talk about the costs that are avoided, as well as the lives that are saved. So I know that, I will ask my client if they know of any studies, but I think we know that when, a mom and a wife dies and it's a young family, what that means. So thank you so much, and hope that you look favorably on Senate Bill 923. Thank you.
Thank you very much. Do we have any questions from Ms. Brocado? Okay, seeing none, we'll move on to Robin Elliott for the Maryland Dental Action Coalition.
Good afternoon. As you've heard, I'm Robin Elliott with the Maryland Dental Action Coalition in full support of this bill. I want to thank Senator Washington and really all of you that have been working so hard to address maternal morbidity and mortality. MDAC would just like to mention that there may be a need for a clarification in the bill. I'm happy to share that this summer, the department is going to start postpartum coverage for dental. So that's a new thing, and it would be great if the bill could acknowledge that. I just want to acknowledge that that's due to the leadership and advocacy of Senator Guy Gazzoni and his colleague on the other side of the street, Delegate Mike McKay. Very much appreciate their efforts and all of your efforts on dental. One of the reasons it's important is we know that when mom goes to dental care, it's far more likely that the child will go to dental care. And the American Academy of Pediatric Dentists recommends that all children see a dentist within a year. Unfortunately, only 1.5% to do, compared to about 90% of children see a primary care provider. This is a huge gap. So if we can accommodate and facilitate new moms getting dental homes, we'll be able to help the new children as well. Thank you.
Thank you. Are there any questions for Robin?
Madam Chair?
Yes.
One quick, I'm just curious that, when my first term here in General Assembly, I had legislation dealing with postpartum depression, and it required that hospitals give, upon discharge, certain information, hotlines, because I didn't really fully appreciate what a huge issue that was. And so Robin, when you start talking about dental benefit, it's not clear to me, just curious, is there anything within the Medicaid menu of funds available program, that deals with postpartum mental health depression issues, or is it all physical and now dental? I'm just curious about that, because it was a big to-do at the time, that legislation. It was, something I kind of got into, so.
Yeah, great question. So the Medicaid coverage right now for women when they're pregnant and then the 60 days postpartum very much includes behavioral health and somatic care. And starting in June will include dental care. Okay. So the wonderful thing about Senator Washington's bill is it takes this comprehensive approach to healthcare. So no matter where or why the woman is at risk, you can get the services to her that she needs. So it's a really great question.
Okay,
And if I
thank you.
could say, Senator Feldman, thank you so much for that. I hadn't even thought about that if you are getting behavioral health, it takes a while to develop a relationship with your therapist. And so for that to just stop after 2 months could have real negative effects. So, yeah.
No, that's a great point, Senator. That's great. Thank you, Madam Chair.
Okay, thank you. Okay, we're going next to Jane Caridi. Oh.
Hi, good afternoon, everyone. Chairman Kelly, Vice Chair Feldman, and members of the committee. My name is Jane Krinke, and I'm here on behalf of the Maryland Hospital Association in strong support of Senate Bill 923. So as you've heard, follow-up care is critical for all birthing persons, but especially for those with chronic conditions and pre-existing health and social challenges. So extending Medicaid coverage from 60 days to 1 year postpartum has been recommended by numerous state and national groups. I believe you've heard a few mentioned earlier today. So this bill would address coverage loss, promote continuity of care, and also complement the state's ambitious and life-saving goal to reduce the overall severe maternal morbidity rate. So as part of our total cost of care model agreement with the federal government, the state submitted a statewide integrated health improvement strategy in December. So this document includes goals for 3 population health domains: diabetes, opioid use disorder, and maternal and child health. For the maternal and child health domain, the state committed to reduce the severe maternal morbidity rate by 19% by 2026, focusing on closing the racial gap by reducing the Black non-Hispanic rate by 20%. So we believe that passage of this bill could really support those efforts and serve as a great complement. This bill also addresses care coordination and health literacy education, which is critical. We support a proposed amendment that would perhaps strike the language at the top of the bill and just clarify the intent, and maybe have the Department of Health work with stakeholders to develop materials that are, consumer friendly and can help patients as they disenroll from Medicaid to promote continuity of coverage. So just like to close with, everyone has a role to play in improving maternal health care, hospitals, payers, and the community. And this bill is a good complement to the state's current work streams to improve maternal health and eliminate racial disparities. So for these reasons, we'd ask for a favorable report on Senate Bill 923. Thank you for your time.
Thank you. I see Senator Reedy. Was your question for this witness or for the last witness? We were just in this section when I realized you.
Madam Chair, I had a question I'd like to ask, but I can wait till the witnesses have been. I was in and out of the committee because I was presenting a bill in another committee, but there was a question I wanted to ask for the record.
Okay.
And we can get to it maybe when the
Go
panel is done.
ahead. Go ahead.
So I'm confirming, I had a conversation, I think, with one of our panelists earlier about this bill, but Senator Washington, working on this issue, just want to confirm sort of for the record, this is about after a child has been born to a mother on Medicaid, and it's allowing the mother to have Medicaid coverage for up to a year rather than just 60 days, correct? Because the child has coverage.
Correct.
Correct?
Yes, and so it's allowing both of them to be able to continue.
Right, and so it only deals with that, it deals with that period of time, and it expands eligibility for a mother. Well, they already have expanded eligibility, correct? Up to 250% of the poverty line.
Right. And but then again, the coverage specific to the pregnancy-related issues can be extended for the entire year.
Yeah. So this bill really just speaks to that. It covers post-birth, postpartum, up to a year, rather than just the 60 days now.
That is correct.
Thank you very much.
Thank you. Also, for the record, I support the amendment of striking that initial language, just to be clear, at the beginning part of the bill.
Okay. Are there any other questions? All right. Good hearing, and that ends the hearing on this bill.
Thank you. Thank you, Madam Chair.
Thank you.
Thank you very much.
All right. We're going next to Senate Bill 815. Senator Casemeyer.
Thank you, Madam Chairman. Senate Bill 815, Mental Health Facilities, Sexual Abuse and Harassment, Reporting and Preventing. There I am. In 2018, the General Assembly, Senate Bill 815 requires private residential treatment centers, and private hospitals with inpatient psychiatric services to report complaints of sexual abuse and harassment to various agencies. They must implement policies and procedures on how to respond to the complaints and develop a written protection plan as a part of the treatment plan for the patient. In 2018, the General Assembly passed legislation that required Maryland's private residential treatment centers to report allegations of sexual abuse. The legislation before you expands on this law by codifying that private residential treatment centers and private hospitals provide the written protection plans to their patients. They must also reassign patients, if possible, to ensure that victims and alleged abusers are not housed together. I've submitted a clarifying amendment that expresses that these reporting requirements are for inpatient services only. And with me today, I have Lucine Parsley from Disability Rights Maryland, who can discuss the importance of expanding upon these previously passed requirements. I thank the committee for their consideration of Senate Bill 815 and ask for a favorable report.
Thank you. Are there any questions for the sponsor? Okay, if not, then we're going to Lucine first. And you have 5 minutes. All other witnesses will have 2.5.
Thank you, Madam Chair, members of the committee, my own Senator Washington. Thank you for the opportunity to testify before you today. As you heard, I'm Lucine Parsley. I'm the legal director at Disability Rights Maryland. We are a nonprofit law firm for individuals with disabilities and their families. We are the designated protection and advocacy agency for the state of Maryland. We are federally mandated to advance the civil rights of individuals with disabilities. In particular, we monitor abuse, neglect, and rights violations in Maryland state and private hospitals, the psychiatric hospitals, and residential treatment centers for youth. A large portion of our mental health advocacy has focused on enforcing and reforming sexual abuse response, including prevention, treatment, and regulations designed to protect children with behavioral health disabilities from abuse. So we strongly support Senate Bill 815 just because it strengthens sexual abuse prevention and response requirements for Maryland youth and adults with behavioral health disabilities. Studies consistently confirm 50 to 80% prevalence rate of sexual and physical abuse amongst persons who later acquire mental health diagnoses. So children and adults in inpatient and institutional placements are particularly at risk of sexual abuse. As we have noted in our investigations, they're away from their family supports, trusted adults. Maryland has not been immune from this problem, as exemplified by a Maryland residential treatment center where several staff were indicted in 2019 for abuse of youth in their care. That RTC Jefferson School in Frederick closed in August of 2020. In 2016, Disability Rights Maryland, my organization, entered into a settlement agreement with the State Department of Health to settle Doe versus Department of Health and Mental Hygiene. We have worked cooperatively with the department to get comprehensive changes to the state hospitals and state-operated residential treatment centers and how they prevent and respond to sexual abuse in the state facilities. Senate Bill 815, however, would expand many of those policies and requirements to private inpatient psychiatric facilities serving youth and adults. During the 2018 General Assembly, Delegate Valentino Smith sponsored House Bill 1130, which required the residential treatment centers, the private residential treatment centers, to report inappropriate sexual behavior. That bill passed unanimously. That bill, which is now law, has resulted in a number of positive outcomes for our youth, especially in the residential treatment centers. So As it is now, whenever a staff member observes or receives a complaint or has reason to believe that an individual has been subjected to inappropriate sexual behavior, they must report to Child Protective Services, law enforcement, the Behavioral Health Administration, Office of Healthcare Quality, and us. So, and those of you who don't know, a residential treatment center is a psychiatric institution that provides campus-based intensive and extensive evaluation and treatment for children and adolescents, usually up to 21, with severe chronic emotional disabilities. So Maryland has 6 RTCs that are licensed by the Office of Healthcare Quality to serve only boys. One serves younger children, ages 5 to 13. The others are co-ed and serve adolescents. So prior to 1113, Disability Rights Maryland was, as I said, receiving reports from only the 2 state RTCs. In 10 years, we received about 42 reports of sexual abuse in RTCs. And after the bill, the House Bill 1130 went into effect on July 1st of 2018, since then, in just over 2 years, we've received over 40 reports, most of them, 33 of them, from the RTCs that are newly required to report to us. So it's likely we would not have known about those prior to finding out about this. And we were typically finding out about them incidentally when monitoring the facilities. So this indicates to us that sexual abuse is still is likely more prevalent than we had anticipated, and pointed to the need to really proactively address sexual abuse by strengthening statutory protections. And so what we are proposing is that many of the things from DOE, including the creation of protection plans, risk assessments, additional training for staff and people who are institutionalized in these facilities, receive training on sexual abuse, and that there be reporting within 24 hours to the Office of Healthcare Quality and to these others, so that there's follow-up and treatment for individuals. I will state Legal Aid Bureau received a request to testify and intended to come, but the attorney who does the legal assistance provision in the state hospitals was not able to come today, but asked me to convey her support for the bill. Legal Aid Bureau also represents many of the children in residential treatment centers because they have the CINA, Child in Need of Assistance contract, and many of those children end up in residential treatment centers. So the sexual assaults at RTCs and the ones that we have been learning about in the private facilities indicate why Senate Bill 815 is needed. It requires these increased protections for youth and adults with behavioral health disabilities. Many of them were created with the technical assistance from SAMHSA as we developed the settlement agreement in the DOE settlement, which again applies only to the state hospitals, but represent best practices for preventing and treating sexual abuse. So with this, we ask for your favorable report, and I'm happy to answer any questions.
Thank you. Very interesting hearing. Do we have any questions for this witness? Okay, I think you covered the waterfront, eh?
Thank you.
Okay, thank you. All right, and our final witness on this bill is Emily Allen from the Mental Health Association of Maryland.
Good afternoon, Madam Chair. I just want to make sure you can hear me since I had that problem last time. Good.
Yes.
Thank you, Madam Chair, Vice Chair, members of the committee. My name is Emily Allen. I'm the Public Policy Associate for the Mental Health Association of Maryland, here in support of SB 815. The Senator and Ms. Parsley have done a great job explaining the requirements of the bill and its background, so there's just a few things I wanted to touch on. Like she said, the population we'd be expanding these reporting requirements for in this bill are our children and adolescents who have severe and chronic emotional disabilities. We know what kinds of negative effects childhood trauma and abuse has on the brain, the impact it can have on that child's future. It can leave them vulnerable to further mental health issues, including depression, addiction, and post-traumatic stress disorder, especially in cases where there's very little parental support. Children in residential treatment centers are already away from the people who can provide that support and trying to manage a severe disability. They're at these centers for help and support, not to have their situation made worse by something that goes on while they're there. Children with disabilities are at a higher risk for child sexual abuse, but they're also less likely to receive the services and supports they need to heal and pursue justice. And the changes proposed by this bill would both provide those supports and work to prevent repeated issues in the future with both themselves and other children. And for these reasons, we urge a favorable report. Thank you.
Thank you very much. Are there any questions for this witness? Okay, I guess not. We had good witnesses for this bill. Okay, thank you. All right, we're going next to Senator Carrozza, Senate Bill 891. Okay, Senator, you have as much time as you need to lay out the parameters for your bill. And your lead proponent is Mary Peroka. That person will have 5 minutes and other witnesses will have 2.5 minutes each.
Thank you, Madam Chair, and to all the members of the esteemed Senate Finance Committee, and happy birthday to Senator Malcolm Augustine. So I'm here to present to you Senate Bill 891. And Senate Bill 891 would authorize the Maryland Department of Health to maintain a list of perinatal hospice programs on its website and authorizes physicians and nurse practitioners to share the information with families who want the information. A little bit of background: perinatal hospice and palliative care is a specialized care provided to families when their baby is given a life-limiting diagnosis and may have just days or hours to live after birth. From the time of the diagnosis through delivery, the multidisciplinary perinatal hospice team provides physical, emotional, and spiritual support. These services empower families to process the diagnosis, find moments of meaning, and welcome their baby and say goodbye. These perinatal hospice services are widely accepted by medical professionals, including the American College of Obstetricians, the Society for Maternal Fetal Medicine, and the American Academy of Pediatrics. There are over 300 perinatal hospice programs in the United States and 9 programs in the state of Maryland. These programs emphasize dignity and comfort and a peaceful experience for the whole family. 7 states have passed similar legislation requiring their health departments to provide perinatal hospital resources and make it easily accessible on the website. Echoing other states' progress on access and transparency to these services, Senate Bill 891 would advance awareness of perinatal hospice in Maryland and greatly benefit families during a very difficult time. Madam Chair, as an active member of the Maryland General Assembly's Women's Caucus, I recently had the pleasure of hearing from Dr. Dina El-Metwali, who is a member of the Maryland Perinatal Clinical Advisory Committee at the Maryland Department of Health for the Task Force of Renewal of the Perinatal System Standards. She's quite an expert, and I learned a lot from her, but I also learned and was alarmed when her research was presented. It showed that there has been a 120% increase of infant mortality in Somerset County, in my district, since the beginning of COVID-19 pandemic. And Dr. El-Metwali suggested that it may be a direct reflection of inadequate healthcare access and prenatal care. The urgency to pass Senate Bill 891 is heightened given that the infant mortality rate has continued to increase and that families often lack knowledge of resources available to them with minimal options. Senate Bill 891 would benefit several hundred Maryland families every year to simply access available perinatal hospice resources. I am pleased to share with you, Madam Chair and members, that the bill has broad support, including several hospices in Maryland, including one in my district, Coastal Hospice in Salisbury, Maryland, the Hospice of Frederick County, Compass Regional Hospice, and Talbot Hospice that oversees Talbot, Caroline, Queen Anne's, and Kent counties. My panel today will explain more about the direct benefits of perinatal hospice services and how it affects the lives of so many families. You introduce the panel and you will hear from them. And I guess I want to share with my colleagues that we in the Women's Caucus have focused on the issue of infant mortality. And I know there are other bills. This is a very limited, narrow bill that would provide some awareness of these perinatal hospice services when families are in that position. I believe it's reasonable legislation. It simply allows information about perinatal hospice services to be made available on the Maryland Department of Health website at a time when families are struggling, coming to grips with a life-limiting diagnosis of their unborn baby, and it could benefit so many from simply being aware of the knowledge that these services are available. And I ask for a favorable report, Madam Chair and members of the committee of Senate Bill 891, and I'm pleased to hear from our witnesses. Thank you.
Thank you. Do we have any questions for our sponsor? Okay, seeing none, we'll go to the main witness, Mary Paratka. She's founder of Rising Hope Perinatal Hospice.
Thank you to Chairwoman Kelly and Vice Chair Feldman and all the members of the Senate Finance Committee for the opportunity to speak before you today. My name is Mary Paratka, and I have been a labor and delivery registered nurse for 40 years. I want to start with what is hospice. For many, that word invokes thoughts of death, dying, pain, and ending. But hospice is really about life. The goal of hospice is to enable patients and families to live their best lives possible, as pain-free as possible, and for as long as possible. Now we add another word to go with hospice, and that is perinatal. The word perinatal refers to the period of time from about the 20th week of pregnancy, roughly halfway through the first weeks of a newborn's life. Perinatal hospice is a concept that has been around for about 25 years. It takes the best of perinatal care and marries it with the best of hospice ideals. But who needs it? Any family that has received a diagnosis of a life-limiting condition for a child yet to be born or a newly born child can benefit from perinatal hospice. Perinatal hospice professionals support families as they make choices and decisions for the future of their baby and family. Perinatal hospice is a multidisciplinary approach that aims to guide through and walk with families during a difficult time. I started the first perinatal hospice program in Maryland about 15 years ago because there was a need. I have been a perinatal bereavement nurse since 1996. My focus was on walking the journey of healing and remembering and memorializing a life lost too soon to miscarriage, stillbirth, or newborn death. One day I was asked to support a family who knew their baby would die soon after birth, but wanted as much time as possible with their baby. As I said, perinatal hospice is about life. It is about cherishing each moment. It is about doing all the things you plan to do with your baby and doing them now, not later. As Megan, the mother of this family, told me, we celebrated every day she was with us. We embraced every moment. Things I would not normally do while pregnant, I did with Rosie, her unborn daughter. We went skiing, roller skating, we went down water slides, to name a few. We had family fun. I took pictures all the time of our entire family and made a note that we were a family of 5. We spoke to Rosie every day we could get, and I made sure to enjoy every kick and movement. I spoke to her often as she was here and living. Perinatal hospice is about celebrating life for as long as it is present, creating memories that will last a lifetime, and setting parents on a journey to healing grief and loss, because there is no shortcut through grief. Caring for grief and loss in the present protects the future mental health of our community. When an anomaly, why is it important for families to be given information about perinatal hospice or perinatal palliative care? Because it expands care options. When an anomaly or life-limiting condition is discovered during testing or ultrasonography, We are reminded that our ability to diagnose surpasses our ability to treat or cure. Although many perinatologists and obstetricians feel they are providing a balanced presentation of options to the family, all too often, that is not the understanding the family leaves with. Families often feel pressured to terminate. Please remember that not giving patients options is not giving them a choice. Families for whom termination is not the right choice deserve the same supportive information and referral to care that abortion receptive women receive. Continuing a pregnancy after a poor diagnosis is a valid choice. It is a choice that leaves the baby deciding the future. It allows the family the time to decide just what is most important for the short time they will have with this new family member. Families who choose perinatal hospice choose a love story, not a tragic journey. Our society doesn't like to think about death, and it is even more difficult to think about the death of children. If any of you have been in the position of deciding the future of a difficult pregnancy, you understand all the dilemmas. But if you have never lived this situation, I ask you to withhold judgment. Many times our patients find that their own compassion causes them to make different choices than they expected. Medicine can't treat everything. Sometimes the journey is the treatment. I have attached some resources to my written testimony. And with these remarks, I urge a favorable report on Senate Bill 891. Thank you for the opportunity to address you this afternoon. It has been an honor.
Thank you. Are there any questions for our witness? Okay, then in that case, we're going to Heather Silver from Silverleaf Counseling. And you have 2.5 minutes.
Thank you. Thank you to the chair and the members of the committee. My name is Heather Silver. I'm a social worker and a perinatal specialist. I run a freestanding perinatal hospice as well as work with families who suffer the traumatic loss of a pregnancy or infant. So imagine going to a sonogram appointment, excited to see your baby's heartbeat, get your first set of pictures, only to hear those heartbreaking words that something is wrong with your baby. As Mary said so beautifully, perinatal hospice is a family-centered care for parents who choose to continue a pregnancy with a life-limiting condition. It creates relationship, it guides in decision-making, and it promotes quality of life for baby and family based around the family's hopes and wishes. It's astounding how many providers are still not aware of what perinatal hospice is, let alone that there are even local resources for their patients. These services prove over and over again that they impact mental health in a positive way. Brochures highlighting these resources should be given to the physicians because not only are they present when the diagnosis happens, they're chosen by these families and they're trusted for guidance. Without information, parents run to Google, which often leads to harmful misinformation. Leaving the office with resources in hand is vital, and the health department should be a trusted source for this information. So I want to give you an example of 2 families who've recently come to me. The first family was a direct referral at the point of diagnosis at 20 weeks gestation. Their daughter Abigail had a major heart defect. We helped the family process, outline their hopes, manage their expectations, all while planning for birth and for death. We recorded the baby's heartbeat, we did professional photos, performed a baptism, and part of our program was explaining death to their other children that was age appropriate and providing legacy building activities to honor their sibship, as well as helping the parents anticipate what their other children needed. Burial and funeral plans were completed prior to birth, allowing them to fully focus on the limited precious time that they had once Abigail was born. The meaning making that happened from pre-planning for the mom to donate not only the baby's heart valves, but also breast milk helped her through a lot of feeling that the baby continued to make a difference. The second family came to me, to one of my support groups about 3 months after losing their son Isaiah, also to a heart defect. After hearing Abigail's family speak, they stated they were unaware that this kind of care even existed. They felt cheated out of the experience to make plans during the pregnancy, as well as to find any joy. They recalled the hospital staff being very compassionate and taking some photos, as well as providing a memory box, but it was too late, and their grief was now compounded with anger, resentment, and trust issues with providers, and this needs to change. This is a bill that will empower parents to make decisions for their baby because they deserve a choice. They deserve information. They deserve your vote, which honors the relationship with their baby and gives them control over something when they are swimming in a river of unknown and of grief. For this reason, I urge a favorable report for Senate Bill 891. And thank you. It was a very big honor to speak here today.
Thank you. Do we have any questions for our witness? Okay, we'll go next to Meg Ashelman from Mother of Maria Grace.
Hello, thank you, Madam Chair and members of the committee. Can you hear me okay?
Yes.
Okay, my name is Meg Eschleman. You have my written testimony, and I would like to share my personal story in order to provide support for Senate Bill 891. In 2010, my husband and I were excited to see the first ultrasound of our first baby. We were smiling and holding hands as we went into the ultrasound, and that quickly changed. We were told that our baby had a neural tube defect. It was quite severe, and if the baby made it to term, she would likely not live past 1 year old. My doctor provided me with all of my termination options, but nothing about continuing the pregnancy. He said I could conceive again soon, and we would be able to fulfill our dream of having a healthy child. And he said, this can all go away. But that wasn't the choice we wanted. As a mom, I think I had an instinctive need to let my baby live as long as possible and naturally reach her full potential. Finally, I found some resources online, as Heather said. I Googled. My husband and I felt alone. We felt sad. We felt abandoned by our medical professionals who were there to help us. But by my research, I did find some resources linked to perinatal hospice. At least I found a community that had some understanding of my experience. And when our daughter, Maria Grace, was born, she was able to have myself and my husband hold her. She was baptized. My parents met her. I love my little girl, and I have no regrets for carrying to term. Pregnancy can feel lonely for women, even when there are no complications. But for that reason, there are so many resources for healthy pregnant women. I believe when things get difficult is when families need the most support from their medical providers. This bill would help families like mine to know they're not alone, that support is out there. If my doctor had known to suggest perinatal hospice from the beginning, my experience and my family's experience would have been much easier. For these reasons, I urge a favorable report on Senate Bill 891.
Thank you very much. Are there any questions for this witness? Okay, thank you. We're going next to Teresa Hessler from the March of Dimes.
Good afternoon, Madam Chair, Vice Chair, and members of the committee. It's nice to see everyone again, and a happy birthday to Senator Augustine. For the record, my name is Teresa Hessler, and I'm here representing the March of Dimes in support of Senate Bill 891. I know already today, many of you have heard discussions on other pieces of legislation and the dire need to address maternal and infant health in Maryland, which ties greatly into this need for this legislation as well. This important legislation will expand the state's current program by offering information on perinatal hospice programs and resources to families and their babies, providing comprehensive support from the time of diagnosis through the time of birth and death of the baby, as well as through the postpartum period. On average, a neonatal death happens in about 4 per 1,000 babies each year in the United States. According to the latest data from the Department of Health, Maryland's rate of neonatal death is about 6 per 1,000, making our state higher than the national average. Some of the leading causes of neonatal deaths are low birth weight, abnormalities, sudden infant death syndrome, maternal complications of pregnancy, and infectious diseases. The diagnosis of a lethal fetal anomaly poses significant challenges for obstetrician, pediatricians, and clinicians who often have had little experience or training in how to best care for the baby and the grieving parents. According to one study, the most profound effect these pregnancies can leave on families without the right care is often a psychological one. Perinatal hospice offers the parents of babies with life-limiting conditions the chance to love and to cherish their newborns for whatever time they have, from a few minutes to days, weeks, or even months. These programs offer a model of care, an extra layer of support that can easily be incorporated into standard pregnancy and birth care. It is for these reasons March of Dimes urges a favorable report on Senate Bill 891. Thank you.
Thank you. Are there any questions for this witness? I'm just looking at a piece of written testimony from Planned Parenthood. And I haven't read word for word through the bill, but they have concerns that there are specified statements in the statute which are to be provided to the parents. Have you any idea of what that's about?
Madam Chair.
Yes.
So I just want to be clear that, the purpose of this bill is to raise awareness of these services. And we're following the model of other states that have successfully moved forward. It does not want to be clear that this is not requiring the doctors or nurses to, it's not requiring them to share the information. It is requiring that the Maryland Department of Health provide a list of services on the website, that it would also the department would make an information sheet available in both English and Spanish, again, informational only. And again, I think you have heard from the testimony is what we have found is that there simply has not been an awareness with either when the parents are in this situation, or maybe even with some providers may not know that these services are available as well. So that is our focus here. And
they don't seem to be saying that what you want isn't good. What they're saying is that there are additional options, and that the statute, the way you've had the bill drafted, would leave out some of those additional options, and that is a concern. So I'm just raising it while you're here.
Well, I guess the way I would respond to that is these are, this information is provided to those who have already made a decision that they are looking for support because they made a decision on those perinatal hospice services. And my understanding from the testimony of our parents is that, and I want to make clear, and this is something that, to me, this bill transcends the abortion debate, because regardless of what your position is on abortion, what we're just saying is that a family deserves the equity of choice if they make that decision to know what services are available if they decide to move forward. So that is the purpose. So I was really actually a little baffled by the Planned Parenthood statement, given the broad support we have for this legislation.
They don't appear to be against the kind of hospice services that you're talking about. They say we oppose the legislation because it's not inclusive of all clinical options, and it mandates healthcare providers relay specific information to patients about perinatal hospice programs. We do not believe it is appropriate to mandate speech for healthcare providers in statute. So they're saying that if you didn't mandate particular things to say in the statute, so that you're directing the healthcare providers who would provide the hospice services, that they would have a different position. I'm just bringing it up because I do see it as an issue.
Yeah, I think there's a miscommunication on it, and going back to the fact that, and maybe the founder, my first witness, might want to address it as well. But again, the purpose of this is to provide information about these perinatal services, to raise awareness, so at least the parents have the option, and that is the purpose. And other states have worked it out. I'm sure we can work it out in Maryland too.
Okay, thank you. And our final witness is Diana Phillip from NARA.
Good afternoon, Chair Kelly and members of the Senate Finance Committee. My name is Diana Phillip. I'm the Executive Director for NARA Pro-Choice Maryland in opposition to Senate Bill 891. Our organization is an advocate for reproductive health rights and justice. As part of our efforts to protect reproductive freedom for all Marylanders, we work to ensure every individual has the right to decide if, when, and how to form their families, and to parent in good health and safety and with dignity. We honor pregnancy in all its complexity, advocate for those who wish to bear healthy children, and fight against reproductive coercion. We respect the expertise of health care and social work professionals in providing comprehensive perinatal and postpartum care, as well as counseling, which includes palliative hospice services for fetal anomalies. We understand the need for maintaining patient-provider trust in regards to reproductive and pediatric care, including the involvement of patients in continuity of care and pregnancy decision-making. We are opposed to Senate Bill 891 as we feel it's unnecessary, and the provisions in the legislation would bring potential confusion to those facing a fatal fetal anomaly diagnosis. When such a diagnosis is first shared, a provider begins discussing options with the patient, putting together a team of social workers, pediatricians, OBGYNs, and care specialists to provide care based on the decision of that pregnant patient and her family. These professionals give medical advice based on the needs and wishes of their patients and take in consideration the totality of the circumstances to prevent causing further psychological distress and trauma of the patient. Palliative comfort care is one of the several options along the spectrum of care, which includes abortion care, for pregnant patients faced with pregnancies complicated by life-limiting fetal conditions. When making referrals, the provider team will offer options and programs that have been vetted by the provider. It's troubling that this legislation appears to compel providers to emphasize only one option and interfere in the communication and trust between provider and patient. We object to mandating the State Department of Health to post a statement on its website describing perinatal hospitals as is the only recommended option for a patient that's received such a diagnosis. A patient may also not know that with such a listing of perinatal hospice programs posted on a state-funded website, that all the programs have been personally vetted by her provider. It may not include the range of care options that have discussed and considered. No patient confused about participating in a program under the impression that all options will be made available should face the threat of reproductive coercion if she ultimately chooses to not carry to term. The goals and objectives of the patient must align with the care team. That continuous communication is vital. But we also suspect that the authors of this bill seek to pass legislation towards the goal of establishing a fetus as having personhood by using the words unborn child throughout the bill, which puts all pregnant people in harm's way of losing their bodily autonomy and the right to determine the outcome of a pregnancy. For these reasons, we urge an unfavorable committee report on Senate Bill 891. Thank you for your time and consideration.
Thank you.
Chair Kelly, may I follow up?
Just a minute. Are there any questions for this witness? Senator Reedy.
Thank you, Madam Chair. Diana, good to see you again. I know we've spent some time together on a previous committee. And my question, you're talking about in your testimony, and I've read the letter, you're talking a lot about mandating and dictating, but this bill, I see a lot of may. I don't really see a shall anywhere.
When we analyzed the bill, it did seem that it was compelling and mandating that information, that the provider must provide this information to the patient. So perhaps
I just see
security in the bill.
I see a lot of may add, may this, may that. I'm wondering maybe we could find some clarifying language that might suit. I guess I also think you guys wrote in your testimony, because I've read yours and a couple others, about how it's maybe not necessary. You feel it's an unnecessary bill. I mean, we have a lot of parents that testified and folks that feel that it is something that people should be made more aware of. We're also talking about doing this basically after the decision's been made, where this isn't like talking to somebody who, just found out they were pregnant. I mean, this is like the decision's been made. So I guess I would question whether you're saying it's not necessary. It sounds like there's a lot of people who've gone through this that feel it is necessary.
I have heard the testimony and I understand their point of view. I think that our issue is that having the State Department of Health have a listing on their website with these programs where it has not been made clear whether or not the patient's going to have the right to actually change her mind, to consider all her options and not carry to term. And that's where the providers get concerned, because they want to be able to serve their patients and not feel that once a decision's been made to seek such a program, that they still have the ability and the bodily autonomy and decision to not carry to term. So I think that's how it interferes with the provider and the patient.
Yeah, I mean, okay, but I mean, I don't, when you just say that you don't want the State Department of Health to keep a list of this, I mean, keeping a listing of this, that's not the whole bill, but keeping a list of this, I don't understand how that would make anybody say they can't go and find, they don't have the option to change their mind. I'm probably not going to get anywhere, but I feel like there's a way maybe for us to clarify this a little bit. So, because it sounds like this would be something that would really help a lot of people who are going through a really difficult time.
I understand, sir, but we're also concerned about what is listed on the website may not be those programs that have been vetted personally by the provider who has that relationship with the patient to begin with. And that's where the providers get concerned about information that is supposed to be handed to every patient about these programs when the provider hasn't personally vetted whether or not that's really in the best interest of their patient and what the patient wants.
Okay, thank you.
Okay, are there any other questions? Okay, if not, then that ends the testimony on this bill. And we'll go next to Senate Bill 423, Senator Salem.
Thank you, Madam Chair.
Thank you, Madam Chair and Vice Chair and Committee. For the record, it's Senator John A. Saling, and I'm introducing and presenting Senate Bill 423, removing funding for abortion. We know that life begins at conception and abortion ends life, and it's that simple. Babies, no matter what stage of development they are in across our state and our nation, are being killed every day because of federal and state funding for the operations. We say it's okay to end life in a womb, but we outlaw ending the life of criminals who kill, rape, and torture other people. We say we wear masks because it may harm other people. Yet when it comes to a life in the mother's belly, her actions to end that life goes unquestioned and unchampioned. At the end of the day, we are not only accountable to our constituents, including those whose lives are taken before birth, but we also are accountable to the Creator, to whose law we disobey every time we support funding for abortion. We should not wrap their rights of one part of society around the idea of taking others' lives, because abortion ends life. And we are going to continue to allow the funding for operations. Then we need to be clear and be honest with ourselves and our way that we justify funding abortion. I want to be clear that I do not want to end the funding for other health services for women. That's not what this bill is about. But I wanted to end funding for the procedure that takes life away. When it's a contentious issue, it is only fair that our state should not be funding abortion procedures. For this cause and for this reason, I urge a favorable report, and we need to stop funding this. Remember, life is precious. Thank you, Madam Chair. Thank you, committee.
Thank you. Let me just ask you, Mr. Sponsor, if an 11-year-old child were kidnapped and raped and as a result became pregnant, are you saying that among the choices available to that child should not be abortion?
I'm saying the funding for my taxes and other people's taxes is a problem. That funding should not be there for that. I don't support it. There's a lot of people feel the same way. And by the way, this is just a handful of people in the state of Maryland that I got. They were telling me that they support this with emails. So it's not just a handful of people, it's a lot of people saying they should.
I'm asking you about a case where an 11-year-old kid is kidnapped and brutally raped and as a result becomes pregnant. And should she have to go through 9 months of carrying that pregnancy in spite of how it happened and that she's only a child? And should she be forced to be a parent to that child if that is not appropriate?
You know, it's a terrible thing. Those things happen. It happens a lot. There's times we don't understand or we don't even find these situations out that happen. But I'm going to say this, in the eyes of the Creator, life is precious. And I don't want to fund any abortions. And that's how I feel about that. Again, I don't believe that it's right for people to rape. That's why I said it's criminal that people do that. But in the eyes of God.
I'm thinking about an 11-year-old child with the aftermath of the whole thing. And to say that I should limit the choices available to someone who's been so horribly victimized is just an innocent child.
And Madam Chair, I understand, but I'm thinking about the life of that baby.
Well, I'm thinking about the life of the child and the 11-year-old. Okay.
Yep.
Are there other questions of our sponsor? Okay, then let's go to Liliana Norcatis.
Good afternoon. I can't turn my camera on. It said that the host has stopped it.
Well, if that's not your picture, we are seeing somebody.
Oh, okay. Here we go. There we
Okay.
go. Hello.
Yeah, there you go. Okay.
Good afternoon, members of the Senate Finance Committee. My name is Liliana Norkitis. I'm a 17-year-old resident of Harford County, and I'm a junior at Falston High School. Today, I am testifying in favor of Senate Bill 423 as an advocate for the unborn and as a proud Catholic. State-funded abortions are against religious freedom. As a Catholic, it aches me to pay taxes knowing they will be used to kill babies. It is our duty as humans to be the best versions of ourselves, but is this how society has progressed? The government gets to take our money to commit mass child murder. This is simply unacceptable, which is why I am in favor of prohibiting state and federally funded abortions with the exceptions laid out in the bill. Maryland performs 3.5% of all abortions in the US, yet we are only 1.8% of the US population. 82 innocent babies fall victim to abortion every day in the state of Maryland. We must do better. It is bad enough an abortion can be performed for a fetal anomaly, yet the baby has proven its viability. But the question today is not about the immorality of abortion. The question today is whether the Senate or whether the state should have the authority to fund these vicious acts of murder. And I am undoubtedly favorable for Senate Bill 423 because the state should not murder children, and it is that simple. I want to thank Senator Salling for sponsoring this bill, and I ask for your favorable report of Senate Bill 423. Thank you for your time.
Thank you. Are there any questions for our witness? Okay, then we'll go to the next witness, Laura Bogley, from Maryland Right to Life.
Yes, good afternoon, Madam Chair and esteemed members of the committee. I'm Laura Bogley and I serve as Legislative Director for Maryland Right to Life. I thank you for the opportunity to speak with you today. On behalf of our chapters and members across the state, I ask for your favorable report of Senate Bill 423 with the amendments submitted to the committee. We thank Senator Salling for bringing this important legislation that prioritizes the state's interest in human life and restores to the people our natural and constitutional rights to life, liberty, freedom of speech, and religion. The Supreme Court has held that state abortion funding restrictions are constitutional and that states may distinguish between abortion and other procedures in funding decisions, noting that no other procedure involves the purposeful termination of a potential life. State funding for abortion on demand is in direct conflict with the will of the people. In fact, 58% of those surveyed say they oppose taxpayer funding for abortion. Still, Maryland taxpayers are being forced to pay millions of dollars each year to cover costs for elective abortions and to otherwise subsidize the $2 billion abortion industry. This bill will equip the state to invest in real solutions for women and families. Women have better options for family planning and well-woman care. There are 14 federally qualifying health centers for each Planned Parenthood in Maryland. 80% of people polled favor laws that protect both the lives of mothers and unborn children. This bill will stop the bleed of public funds to abortion and prioritize health and family planning services which have the objective of saving the lives of both mothers and children, including programs for improving maternal health and birth and delivery outcomes, well baby care, parenting classes, foster care reform, and affordable adoption programs. For these reasons, we respectfully urge you to vote in favor of Senate Bill 423 with amendment, and we thank you for your consideration for the equal value of each human being, born and preborn. Thank you.
Thank you. Senator Reedy?
Thank you, Madam Chair. Laura, a quick question for you, because alluding back to the chairwoman's questions to Senator Salling, in this bill has an exception for rape, incest, and life of the mother in jeopardy, correct?
That's correct.
So we're not talking about, so then those specific cases like were brought up, which are horrible, unthinkable, that is not, this bill does not affect that.
That's correct. As written, the bill makes an exception for rape, incest, and life of the mother.
Right. So yeah, we're talking about taxpayer funding for elective. Thank you very much.
Okay. I will just say that I was responding to what I'd heard the sponsor say at the time that he put it forth. I hadn't read through it all, but I do see those. But he mentioned also some amendments, and I don't see the amendments. So if you have some amendments, Senator, you want to get us the amendments so we have everything that you want us to consider.
Yes, Madam Chair.
Okay. All right, then we're going to Laura Bogley. Oh, okay, Robin Elliott.
Good afternoon, Robin Elliott. I'm here representing Planned Parenthood of Maryland. We are opposed to Senate Bill 423 because it is broad-reaching and it affects abortion coverage in not just Medicaid, but on the Maryland Health Benefit Exchange, even the state employee health plan, and potentially if state funds are available for other types of health plans. We believe that abortion care is part of health care and should not be excluded from health insurance. And so for this reason, we would ask for an unfavorable report. Thank you.
Thank you. Are there any questions of this witness? Okay, and our final witness is Diana Phillip. Oh, she written only. Okay, I thought that was oral. All right, that ends the testimony on this bill and our hearing for the day. Members of Senate Finance, we will assemble for voting at 3:30 in the committee room. Thank you.